So, on behalf of my research team, my co-authors, I would like to thank the program committee for selecting my research topic. My name is Taniguchi from Chiba University, Japan. I'm going to talk about the cost effectiveness of rapid versus delayed ART initiation in Japan. Here's my disclosures. So initiating ART is frequently delayed in Japan due to time required to secure medical support certificates. So we want to start ART as soon as the confirmatory test is positive. But in the Japanese system, we need 2 sets of lab, which includes CD4 count and viral load, at least 4 weeks apart. And then we could apply for the physical disability certificate. And then we could apply for the self-support medical care system, which covers the medical expenses for the HIV care. In some cities, they approve ART initiation upon application for the physical disability certificate, which simultaneously would apply for the self-support medical system. You will not need 2 sets of lab if you have AIDS-defining illness. There is another rule in Japan, which if your CD4 count is over 500 and your HIV viral load less than 5,000 copies per ml, you don't qualify for the physical disability certificate. And that results in about 1 to 2% of newly diagnosed HIV being ineligible for the physical disability certificate, so you can't start ART in these patients. So this is the result of a survey conducted in 2024, asking the time from HIV diagnosis to ART initiation categorized by the year of diagnosis. And if you look at the recent data from 2019 to 2024, about 54.3% of newly diagnosed HIV took over 1 to 2 months to start ART. But if you look at the those people in the green and orange, they are people who started ART within a month. But those are the patients who had AIDS-defining illness. That is late presenters. This is from a different study, but the median time from diagnosis to ART initiation is about 42 days, which is 6 weeks in Japan. And this is from the same survey, but asking the thoughts and feelings immediately after HIV diagnosis. And you could see that a lot of people are anxious and depressed when they're diagnosed with HIV, affecting their health-related quality of life. In the right graph, it is showing the average values of negative emotion immediately after HIV diagnosis, comparing to the current status when the survey was taken. So you could see that there's a lot of negative emotion when you're diagnosed, but it resolves with HIV care and treatment. So I think rapid ART is a really good thing, and we wanted to show the stakeholder to convince that rapid ART is cost effective. In order to do that, we constructed a Markov model to predict HIV disease progression over 40 years horizon. And each month, patients transitioned among 4 CD4 categories: ART status, which is on ART with suppression, not suppressed, off ART, and dropout, and death. We applied age-stratified background mortality rates, age-specific mortality multipliers, CD4-specific disutilities on monthly cost in Japanese yen. The model outputs included total discounted costs and quality-adjusted life years, QALYs, at a 3% annual discount rate. And we compared 2 strategies. One is ART initiation immediately upon diagnosis, which is 0-month strategies. And 2 is the standard of care in Japan right now, initiating ART around 2 months after diagnosis, which is 2-month strategies. And those with CD4 count over 500 and viral load less than 5,000 copies per ml cannot start ART. We conducted both single cohort analysis of 30-year-old MSM and population level analysis, which included the distribution of age, sex, and baseline CD4. So we took the medical costs from the hospital claims database, and medical expenses of the ART in Japan is about 2.26 million yen, Japanese yen, per person per year. And that is roughly about 16,000 US dollars per person per year. This is a model structure. We have pre-art, on-art not suppressed, dropout, which could transition each other. And we also have death, which is cycle stops. We also have CD4 categories, which is not shown in this diagram, but it improves when you're on ART, and it gets worse when it's not suppressed or if you're a dropout. In the 2-month strategies, CD4 count over 500 and viral load less than 5,000 copies per ml stays at pre-ART, or it could transition to dropout or death. So this is the result. In the deterministic single cohort analysis of 30 years old MSM, 0-month strategies incurred total discounted lifetime cost of 68.95 million Japanese yen and yielded 223 QALYs. And 2-month strategies had total discounted cost of 50.65 million Japanese yen and yielded about 215 QALYs. So the incremental cost was 18.30 million Japanese yen, and incremental QALYs gain were 7.55, resulting in ICER of 2.43 million Japanese yen per QALY gained. In the population-based analysis, accounting for the distribution and baseline CD4 counts, age, and sex, incremental cost was 5.02 million Japanese yen, and incremental QALY gain were 2.27, resulting in ICER of 2.22 million Japanese yen per QALY gained. In the probabilistic sensitivity analysis, at the willingness to pay threshold of 5 million yen per QALY, the 0-month strategy was cost-effective in most simulations. The cost-effectiveness acceptability curve showed how the probability that the 0-month strategy is cost-effective rises rapidly above typical Japanese thresholds. And in the one-way sensitivity analysis, pre-ART disutility, age-related mortality multipliers, dropout probability, and cost related to pre-ART care were identified as the main drivers of uncertainty. So to conclude, our findings suggest that rapid ART initiation at the time of HIV diagnosis is likely to be cost-effective in Japan, with an ICER of consistently below the common threshold of 5 million Japanese yen per QALY. Although institutional requirements currently delay ART initiation, these results highlight the potential economic and health benefits of streamlining administrative process for earlier ART. Policymakers and healthcare providers should consider revising the current guidelines to facilitate immediate treatment access, thereby improving both clinical outcomes and overall efficiency of HIV care in Japan. So this work was supported by the Ministry of Health, Labor and Welfare, AIDS Policy Research Program, and these are my collaborators. Thank you so much for your attention.